Thank you so much, Bill, for that kind introduction. I am back in Texas, and I'll tell a little story about Texas. I grew up in Minneapolis, and I came to UT Southwestern Parkland Hospital for my internship, and I was in the emergency department for my first rotation in July. And I don't know if most of you ask patients as a mental status question who the President of the United States is, but that's what I was used to. And in the emergency department, those early days, in the cubicle next to me, I heard another intern ask, "Who's the coach of the Cowboys?" And I thought, who's the coach of the Cowboys? And a little tiny elderly voice said, "Tom Landry." And I thought, I'm not in Kansas anymore here. So it's great to be back. Thanks, Bill, for that nice introduction and for helping frame why I have chosen to talk about patient-centered care and shared decision-making. That was a great introduction. I could certainly have elected to give a lecture on heart failure or transplant, but that would be bringing close to Newcastle. You have international experts here. And so what I really want to share with you is a little bit of not only my journey in getting involved in patient-centered care, but also some of the interesting things in cardiovascular medicine, what's coming, what's already here, and then I think importantly, what some of the mandates are going to be with regard to health policy going forward, because this is something we all need to know, no matter if you're a cardiovascular specialist, anesthesia, a surgeon, these are all things we need to pay attention to. So where does patient-centered care, this term, come from? Well, these are the Institute of Medicine core principles, just to remind you. And the Institute of Medicine talks about medicine that is safe, effective, patient-centered, timely, efficient, and effective. So patient-centered is right in the middle of those constructs. We are all in this room really familiar with disease-centered care. We do this in spades. Cardiovascular specialists have more guidelines than any other field in the world. Anybody else? Because why? We invested early in randomized controlled trials. We understand data. We're very data-driven. And many of our day-to-day decisions that we make are very disease-centered. A patient has a disease, a medical problem, some type of iteration of that disease. We go to the guidelines. We go to the original evidence. How does my patient fit into this particular algorithm for this disease? So we know how to do this. We're good at this already. But let's talk a little bit about what we're not as good at. This is a really important paper that was published in the New England Journal several years ago now by David Rubin and Mary Tanetti. They are researchers who spend a lot of time in geriatric medicine and in particular some interest in geriatric cardiology, thinking about how patients feel and what goals patients have. So this is a figure from that paper that shows you the various measurement domains on the left, examples of disease. Then we have traditional outcomes versus what are termed goal-oriented outcomes. So survival is a measurement domain. In fact, that is the domain that we measure in almost every trial we do. We're not that into surrogate outcomes in cardiovascular medicine. We're counting the bodies and saying who does better. Of course, there's MACE and there are other interventional trials, but a lot of our trials are really focused on mortality or survival. So that's a traditional outcome for a trial, but it is not a goal-oriented outcome for every patient. It may be if a patient is interested in meeting a goal, living a certain amount of time to see grandchildren, to get to a wedding. So it can be a goal-oriented outline, but not always. Excuse me, biomarkers. We have used biomarkers as outcome surrogates. Biomarkers are not a goal-oriented outcome at all. Now, some of your patients, especially our heart failure patients who are told what their BNP is, sometimes end up getting a little bit crazy with thinking about their biomarkers, but it is not a goal-oriented outcome, though sometimes I think we mix that into our own beliefs. Signs and symptoms can be both. When we think about measuring outcomes for research investigation, signs and symptoms can be important, and especially functional status, which is on the last row. So functional status can be an outcome that we're looking at for a new therapy, but it is the ultimate goal-oriented outcome for patients. So one of the things I would like you to take away from this morning is to think a little bit more with your patients about their goals. And it's not an easy thing to do because patients are no more used to assessing their goals than we are at eliciting their goals. If you just try that in clinic today, if you have clinic, it's hard to do in the hospital. Can't really, unless the patient's facing a surgery or something. What are your goals will get you a blank stare. But the more you engage your patients in what their goals are, the tighter you become as a team with that patient, and you can help them make decisions better. So why do we care about patient-centered care? Why did the Institute of Medicine embed this in the principles? It's very clear that patient-centered care improves disease-related outcomes and quality of life. People who are treated in a patient-centered manner adhere to their medications more commonly, and their chronic disease management is easier. I think one of the most important aspects of patient-centered care is it directly addresses racial, ethnic, and socioeconomic disparities in care. And this is a huge problem in all of medicine, but certainly is important for us in cardiovascular medicine. And I'm going to show you a lot about the decrease in overuse of diagnostic testing and procedures if we use patient-centered care. The other reason to pay attention is that our reimbursement is more and more going to be tied to patient-centered care in a variety of ways. The current policy efforts or recently passed all include patient-centered care elements, and these include value-based purchasing, the National Quality Initiative strategy, meaningful use, the patient-centered medical home, accountable care organizations, and the American Recovery and Reinvestment Act. There will be more policies to come. We're in the middle of a sea change in the United States with regard to health policy in view of the new administration. But patient-centered care is not going to go away. This has already been embedded in a lot of our policies. Bill mentioned this, that I was privileged to chair the Patient-Centered Care Committee, and this is an outcome of that committee. We felt strongly enough, and I co-chaired this with Dr. Beauvais, whose real push towards the patient-centered care began during his presidential year. And we felt that every year, the American College of Cardiology issues policy statements on important issues in healthcare policy, and we felt that it was important enough that the college should have an actual policy statement on this. So I invite you to read this. It's in JAC, and you can download it at your leisure. So when I'm talking about patient-centered care, some of you out there are saying, "What exactly are you talking about here?" You know, I'm a physician or a nurse clinician who focuses on patient-centered care. There are specific elements to patient-centered care that we have to pay attention to. One is our communication. Patient-centered care involves us being more involved with our patients in a lot of different ways, including sometimes electronically, maybe with email, but certainly some of these goal discussions I talked about. In order to deliver patient-centered care, we have to address our patient's health literacy. We have to speak to the patient at the level that he or she is able to speak back to us and give them reading materials that they can actually read. Patient education is important. So is collaborative care planning and goal setting. We already talked a little bit about that. Patient empowerment and self-management. Gone is the time of the patriarchal and matriarchal physician telling the patient what to do. We really want the patient to be managing their own disease process and being empowered. And right in the middle there is shared decision making, and I really want to spend the next part of my time on shared decision making and how important this is for our patients. When we talk about shared decision making, it's different than some of the decisions we've helped patients make in the past. One of the most important attributes of shared decision making is the active engagement of that patient in making the decision. not every decision is best made for shared decision making. When we think about shared decision making, we're thinking about divergent paths, like a patient may be taking a lifelong medication, be that clopidogrel after a drug-eluting stent, be that a statin. These would be decisions that a patient is making with you for really what's probably a lifelong medication. And then there are other decisions, like surgical decisions, major surgeries, generally elective, but also testing that may trigger a whole diagnostic cascade of other testing. So we're not going to engage every patient in every decision. If I come into the emergency department and I've been in a car accident and I have a subdural hematoma, the neurosurgeon is not going to engage me in shared decision making. In the emergency department, the surgeon's going to recommend surgery and get informed consent from myself or my family. This is not an area of shared decision making, but I'm going to show you where some areas that we need to think about shared decisions. So this is a really nice graph showing the respective roles that clinicians and patients play regarding which decisions. So if you have a ruptured appendix, pretty clinician driven. I used the example of the subdural hematoma, but cosmetic surgery is entirely patient driven. You need a surgeon to do it, but the patient is the one making the request. And then we have dual antiplatelets, post-drug-eluting stent. Well, that really is a clinician decision, except if it's an elective procedure, of course, the patient on the front side needs to be involved in that decision about that drug-eluting stent, because what if there's elective surgery down the road? Statins for primary prevention versus a trial of lifestyle modification, very much patient-driven. And a lot of the decisions are kind of about halfway in between. So let's talk about some of those. How many of you are on Twitter? Okay, Dr. Zaghi is. I know that. So I put this out on Twitter with the hashtag shared decision making because I read about this in JAMA. This was in July of this past year. So this was an important study, I thought. I was struck by it. Palliative chemotherapy does not improve quality of life in this particular group of patients. I won't go into exactly which drugs and whatever, but the point being, wow. I said to myself when I read this, do these patients know this? Or are they, as are many oncology patients, continuing down the path trying to fight the disease? So if palliative chemotherapy doesn't change quality of life, and we already know it doesn't change quantity of life, we have to have shared decision making with patients who have this problem. And we need tools to do that, and those are called decision aids, and I'm going to show you a couple of those. This is another really important paper that was not in the medical literature, but it was in the economic literature. And this microeconomist was pregnant, and she wrote this paper because she said how it became clear that I needed to sort through the valuable and useless information on alcohol prenatal texting deli meats for myself. So I didn't know anything about microeconomics, and I learned about it from reading this. Microeconomics is the science of making decisions, and it's a way to structure your thinking when you're making decisions. And in order to make good decisions in life and in business, and I posit in medicine, you need two things. You need the right data, and then the right way to weigh the pluses and the minuses of a decision personally, yourself. The key is that the data is the same for everyone, but the decision is not. The value you personally bring to making a decision with regard to medical care in this case really matters. And so you have to think about the alternatives yourself and know what other person can make the decision for you. So this author was pregnant, and she said, gee, medical care in pregnancy seems to bring a lot of rules. You can only, if you've been pregnant, you've heard this stuff. You can only have 2 cups of coffee a day. The guidelines say you should have amniocentesis only if you're over 35. She said, what if you wanted an amniocentesis under 35. Is that unavailable to you? And 1 or 2 drinks of alcohol drinks a week is probably fine. None of these, well, the amniocentesis has a little bit of literature, but what her point is, none of these are based in research, but yet they're given as edicts to pregnant women in general. And the recognition that the patient, in this case, the pregnant woman, might have different preferences is not acknowledged. So microeconomics is actually overlapped, in my view, with shared decision making. This is an example of a tool that you can use to make shared decisions. If any of us had a herniated disc, we might want to both visit a physician, surgeon, who might want to fix this with a surgical option, but then this is available online. And this is how a decision aid works. You get the facts first, you read about what the decision is, get surgery or not get surgery. You compare your options, which is number 2. Number 3 is you think of your own feelings. This is where your own values come in. You know, am I a person who wants to get things done with? I don't want to think about this anymore. Physical therapy, I don't think that's the way I want to go. Then you make a decision, quiz yourself, and then you have a summary. This is an online tool, and this tool you could then bring to the discussion that you have with the surgeon. You can see that we can't use decision aids in emergency situations. We don't have time for this. We can't have people make decisions for emergency operations or other care. But when we have more elective decisions, we can use decision aids to make those decisions better. This paper was in the BMJ just recently, and some really innovative investigators said, you know, instead of us deciding whether patients with atypical chest pain should be in our hospital overnight for 23-hour observation, we're going to involve the patients. We're going to better tell our patients what their outcomes might be with atypical pain, and they used a pictograph to show it, and they randomized people. They used the decision aid with some, and they didn't use the decision aid with others. And the choice was whether to stay in the hospital for 23-hour observation versus having cardiac stress testing in follow-up within 24 to 72 hours with a cardiologist. So they involved the patients in the decision. And this is the 30-day outcome. There was a decreased rate of admission for advanced cardiac testing and stress testing over the 30-day period. Importantly, especially for those of you in interventional cardiology, no major MACE related to this. Involving the patient, giving the patient the data, and helping the patient decide, and letting the patient decide really mattered. This was in the ER, so shared decision-making is creeping into the ER, which is really amazing. Remember I talked about appendicitis as being not something we could use shared decision-making with? Well, that's not true anymore. Those of you who follow the surgical literature may have found out that in JAMA surgery, people kind of do okay if they're treated with antibiotics, especially young people. And these investigators used a decision aid with patients, but more importantly, their parents for young people, and showed the risks and benefits of surgery versus antibiotics only. And a large majority of patients and their families elected to trial antibiotics. So again, this was an emergency department shared decision aid as well. What about cost? I told you that there was a decrease in elective procedures with shared decision making. And as many as 20% of patients who participated in shared decisions choose less invasive surgical options compared to those who don't use decision aids. In 2008, the Lewin Group estimated that if we implemented shared decision aids for just 11 procedures, there would be a $9 billion savings over the next decade. And in 2012, the group health in Washington State, this is a big area in shared decision aids, which is elective hip and knee surgeries. There was a substantial reduction in these surgeries with 38% fewer surgeries and a savings of 12 to 21% over 6 months. So we won't go into the ortho literature, but as you know, these pain relief with surgery versus other strategies is something that we need decision aids for our patients so that they better understand that. So the cost savings can be significant. This is an editorial in the New England Journal by Zeke Emanuel and Emily Lewis. Emily Lee, it's now 3 years old, and it addresses the Affordable Care Act. We're not going to get into politics, I promise. The Affordable Care Act called out the importance of shared decision-making with our patients in Section 3506. And at the time of this editorial, which was 2013, the ACA had been in place for 2 years, but yet there was no actual policy mandate to do shared decision-making. And what the authors were calling upon us to do, the government to do, and CMS in particular, is to promote shared decision aids for clinicians and patients, improve the quality of decisions, and reduce costs. And they posited that CMS should begin with the 20 most frequently performed procedures. That was 3 years ago, and that has not yet happened, but I heartily agree with that. Until the payers are actually involved and until we have implications for our own practice, it's hard for us to delve into this routinely with our patients. So what about healthcare reform? We're actually beginning to see a little bit of a change. For those of you who aren't in cardiovascular medicine, if you're in primary care, you may know that in order to have your patient, I know you can't read this, your patient have a CT scan as screening for lung cancer, which is a one-time benefit, Medicare benefit for your patients who are former or current smokers, you have to engage the patient in shared decision-making with a decision aid. Now, what CMS has left out, how do we prove that happened? We still don't know what the portal is that we're telling the payers how we've done this shared decision making. But the mandate's here. And in our field, the left atrial occlusion device requires shared decision making. I didn't put it in the CMS document, but this was the front page of the Wall Street Journal. This is Ron Winslow's paper. And what the mandate says, for those of you who use these devices, Medicare's new rule isn't about a second opinion, but rather about ensuring that a patient's own opinion and values are taken into account when weighing risks and benefits. Before Medicare pays for the watchman, a doctor who doesn't implant the device has to talk to the patient. So, in this way, we actually do know how CMS is keeping track, because another clinician submits an E&M code for seeing that patient and discussing this with the patient. This is a type of shared decision making. It is not using a decision aid. It's not, but it's the first policy teeth that we're seeing, showing us that shared decision making is here to stay, and we're going to see more of this. I'm going to show you some cardiovascular decisions that are in need of shared decision making, and some of them have some pretty robust decision aids already, and I'll show you those. And there's a couple of that I have been involved in myself, and a couple that I want to talk about as areas we really need shared decision making, and I think we're failing our patients. So aspirins and statin, primary prevention ICDs, the wearable defibrillator, destination therapy VAD, a therapy that's offered here, and valsartan sacubitril are one of our newer therapies for congestive heart failure patients. This is a statin aspirin decision aid from the Mayo Clinic. Victor Montori and his group at the Mayo Clinic have been very involved in shared decision making. And if you go on the website of the Mayo Clinic, you can download these decision aids. They're very valuable. And this looks at risk of heart attack and takes into consideration patient preference, but also bleeding risk, so that you can help your patient make a decision about using primary prevention aspirin. The University of Colorado, under the leadership of Dan Matlock and Larry Allen, have been very involved in the creation of and research with shared decision aids. They have available that you can use today decision aids for your patients for left ventricular assist devices and also primary prevention defibrillators. So shout out to them for doing this work. And this is a screenshot from their decision aid about primary prevention ICD. Path A is a patient who elects to have a primary prevention defibrillator placed. Again, those are patients whose ejection fraction remains low in spite of the use of guideline-directed medical therapy, who are looking at trying to prevent sudden cardiac arrest. So in the last years of life, we see that generally these, minus some VT that's not addressed by the ICD, I get it, generally these patients are electing a slower death of heart failure versus, I don't want, path 2, I don't want a defibrillator. I understand my risk of dying suddenly, and I'm fine with that. Again, this is a decision I have with patients every day in my clinic. So do many of you. How we don't bring our bias into the room is by using a decision aid. I like to tell the story that when dabigatran was first available, I was chairing a sort of a panel at a CME event at our institution, and there were electrophysiologists on the panel. And dabigatran had only been available for about 4 months, and so I was trying to draw out the EPs into talking about their use of it and their replacement of warfarin with dabigatran. And one senior electrophysiologist said, every patient I've talked to about dabigatran is on it. And another very senior experienced electrophysiologist said, none of my patients are on dabigatran whom I've talked to about it. I can assure you these two people knew the literature, cold, both of them. How they interpreted it may have been different, but more importantly, how they telegraphed the message to the patients clearly was different. With decision aids, we can back ourselves out of the room and let the patient have the decision. Telling a story on myself, I used to tell people when I was having this discussion, we all have a shtick. Come on, we tell patients things a certain way every time. If my patient were over 75, I would often say the research studies that proved benefit for ICDs did not include any patients your age. And I became aware through the work I've been doing in this area that, well, that just throws the whole idea out of the, if I introduce that, if that's what I choose to tell my patient, what patient's that's gonna influence the patient to say no. I've stopped saying that and started to use this decision aid to help patients look at this objectively without our sort of maternal and paternalistic oversight. So this screenshot is also from this decision aid for ICD, and it shows patients in a pictograph, that's what these little bubbly, smiley faces are, how many people die versus don't die with a primary prevention defibrillator. And they can better, with a decision aid, understand this isn't just about risks and benefits, but this is about how much of a benefit there is versus the risk of the procedure. I want to talk about the LifeVest because it is a burr under my saddle. And I'm in Texas, so that's good that I said that. I don't know if it's used in this institution. I will tell you that I have used this slide in other groups, and I have found a huge disparity in how people use this. Some institutions use it all the time. Other institutions have never had one placed. Why do I want to talk about this? It's not about the science behind this. It's about the shared decision that is not happening with patients. This is the marketing for the Zoll LifeVest. This was a fear-mongering ad that we received on March 14th, 2015. If you were signed up for the ACC in 2015, this is what you got in your email, with the patient all tipping over and everything. So really, what's the risk? Is this what we're going to show our patients? You're going to die? What we know about how it's used is very different in different parts of the world. This is USA versus Germany. Recent MIs in green. So in Germany, this is used a lot, at least in this series, for patients recent MI and post-CABG. But whereas in the United States, look at the orange, which is non-ischemic cardiomyopathy. That's newly diagnosed. So a lot of very disparate use, and this is the use and what patients actually do with this defibrillator, or this wearable defibrillator. Some people are wearing it, almost 24 hours a day for 3 months. In my practice, because I'm an advanced heart failure physician, I have had people arrive in my clinic with these on, which is fine if they're at risk. But to a patient, I can assure you, they were not talked to about why they were wearing it. They were simply told they were at risk of death and they should wear it 24/7. This is from people outside my institution and a couple within. We're not big users of it, actually, but the point of bringing it up, and the EP docs here, I get it that there are times we want to use this, but I can say, at least in my practice, I've seen no shared decisions with patients about this. Some people are out of pocket $3,000 a month for this too, by the way, and they're not told that when the LifeVest goes on. So this is an area we need a decision aid. And talking to my friends in Colorado who are making decision aids, they say, it's impossible to do a decision aid, there's no data. So we can't do a decision aid yet unless they're balanced risks. But what we can do is engage in shared decision making without a decision aid to better get our patient involved in this discussion rather than just thinking medical legally, which is, I think, what's driving the use of this device. We are involved in DECIDE LVAD with the University of Colorado as the primary PI center. It's a PCORI, patient-centered research outcome-supported effort. There are 5 sites. We've actually closed enrollment. And what we've done is used a decision aid for destination therapy defibrillators. Patients considering this have used it, and also their caregivers. It has been incredibly valuable. You stay tuned for the data. There's going to be a lot to come. We're going to see what the impression of patients is after using this. There's a term called decisional conflict, and with decision aids, patients routinely feel less decisional conflict when they've used a decision aid. And so we're going to be very interested in the outcome. But this has been a very important decision aid because for those of you who do this, and you probably all take care of VAD patients because you're a big VAD center, we know that there's a lot of rehospitalization for these patients, and we know that the risks include bleeding, infection, stroke. And what this decision aid does is better explain to the patient their course with a destination therapy VAD versus everything's going to be great. We're going to implant this pump for you, and you're going to feel better, your cardiac output's going to go up, and that sort of thing. So this better identifies to the patient what life will be like. Larry Allen and his colleagues wrote a paper about decision aids, in particular in this area of destination therapy, LVAD, showing the overlap of, there is the cost and burden that's to society and to the patient, survival, which is clearly one of our goals with this therapy, quality of life, which is the patient's symptoms and functional status, and then right smack dab in the middle are outcomes relevant to the individual patient. And this is where we can't stipulate this to the patients. The patients are the only one, and the family are the only ones who can really bring this to the fore, what their outcomes are. In the work with the University of Colorado, they've seen quite a dichotomy in how patients view this therapy. One is very reflective and utilitarian. I thought a lot about it. And then the automatic, what other choice do I have? And I think those of us who are in this field face this on the right a lot more. What else could I do? The point of a decision aid is to better help the patient understand what the decision is and what the other choice offers. There are many decision aids out there. There are many institutions working on this. PCORI is I told you about the DECIDE trial. There's an effort at Baylor, Carnegie Mellon. There are a lot of institutions and investigators very interested in the area of shared decision making and they're producing decision aids. What will be coming from a policy standpoint is actually having CMS, likely in the very near future, actually approve decision aids as being appropriate decision aids, and we await this. I think this is going to be a big change in policy that will help us. Another area that we're, at least in my field, are involved in shared decisions with patients is around the new drug, which is valsartan sacubitril, or what was previously known as LCZ696. For those of you who don't see a lot of heart failure patients, this is a medication that, compared to enalapril, offers improved survival, decreased hospitalization, and improvement in quality of life, in brief. However, if you're paying full freight for this medication, it's $12.50 a day. And compared to if you go to Walmart, CVS, or any one of the other pharmacies, enalapril's $4 a month. So this is an area where, although we are talking to patients about a therapy that is beneficial to them and that can result in improvement in survival and their quality of life, we have to bring them into the discussion in a very meaningful way because of this cost. Now, granted, as time's gone on, we're now about 16 months into this. There's a lot of coverage for this by some insurers, but not all. So this is another area that we really need to focus on, the shared decision with the patient, and not just write the prescription or electronically forward it without having a discussion with the patient. End-of-life care is a very important area for shared decisions. This is actually a British website, and it's the NHIS Shared Decision-Making Program. Very robust. The Brits are ahead of us in this, and in particular at end of life. I direct your attention to this website because I think it will help you talking with your patients, not only about palliative care, but also about hospice care. Because this is where shared decisions, the rubber really meets the road, because our patients' values come into play when, in particular, when they're making decisions about code status and where they want to spend the last days, weeks, and months of their lives. And with decision aids and the tools that are available, in particular on this website, you'll have a better conversation with your patients when you need to have that, whether they're outpatients or whether they're inpatients. And I'm going to leave you with this slide, a bunch of doctors around a patient saying, "No worries, when we want your opinion, we will give it to you." Thank you.